Hello and welcome to What, and Why. This is a series really dedicated to discussing important HIV research and publications and shining a light on the vital contributions of women clinician researchers doing this work. I'm your host, Toy Nwafor. I'm an infectious disease physician, professor of medicine. I'm a pharma executive and a passionate HIV advocate. And in this series, really, my goal is to break down the silos and move beyond those firewalls that actually sometimes separate us from the authors of this important research and the audience they're trying to reach and the work they're doing. So what we're going to do in this series is just delve into the unmet needs that prompted these research studies, explore what they did, examine their findings, and hear in their own words why this work is important. So today I'm excited to be joined by my colleague and friend, Dr. Ragan Johnson, who will introduce herself, and she will share her expertise and insights on this important publication. It's called Reasons Over Risks, NPs and HIV Prevention for Black Women. The full article and the show notes are going to be in the show, but I'm really excited to be joined by Dr. Johnson. And Dr. Johnson, please introduce yourself.
Hi, thank you so much for having me. I'm excited to be here with you. So I'm Ragan Johnson. I am a family nurse practitioner by training. I am currently working in academia, primarily in a large institution in the Southeast where I teach mainly, but I have the distinct honor of collaborating with a PhD DNP type collaboration on research around HIV prevention, specifically with Black women, but also with Black adolescent males and young adults. So super excited to be here.
Great. Thank you so much. So we're going to delve into it. We've talked about, the article Reasons Over Risk. And so, a lot of us in research are used to the framework of background, methods, results, conclusions. Well, it's the same thing. What was the issue? What did you do? What did you find? And why should we care, right? So I'm going to start off with what was the unmet need? What was the reason why this needed to be done and published, this work?
Yeah, for a lot of providers, we tend to see, especially nurse practitioners, that could be deeper engaged in primary care around HIV prevention and HIV treatment access. They're not for a lot of different reasons. But one strong reason is their inability to kind of think beyond risk, and how we frame risk for Black women is very stereotypical, is extremely maligning in a lot of ways, and really framed out of historical abuses where Black women were overly hypersexualized and these types of things. So sometimes providers with their own bias assume that Black women's risk is related solely to their behaviors. And when often you speak to people in general, Black women specifically, about sex, if you do it in a judgmental, stereotypical way, then you close off the conversation. And so we really wanted to address that with clinicians.
That is so critical, what you said. That was the unmet need in terms of the language and the assumptions and the biases that come into these healthcare spaces with a vital group of, and I know why you talked about nurse practitioners. This is so broadly relevant to all clinicians providing care. And the impact of this paper is beyond nurse practitioners, so all of us doing this work. So thank you. So what did you do? So you framed kind of the unmet need, why this work needed to be done. What did you do next?
Yeah, so based on a national campaign that was happening through one of the pharmaceutical companies of a similar name, we just kind of reframed it specifically for providers. How can you take this information and reframe how you discuss risk, how you address risk through the sexual health history, right? So even in our questions, how we shape these various questions can be done in a way that is overly stigmatizing. How many partners do you have? Assumes that a person has multiple partners, right? Versus, tell me a little bit about your sex life. if you leave the question open-ended, it allows the woman or any patient really to be able to just answer the question, right? You don't have to, and I know it's not always intentional because these questions have been given to us by other frameworks and CDC frameworks, right? These are recognized, internationally recognized organizations that have created these frameworks without Black women in mind or without thinking how these questions may introduce or cause bias. So I think that it's important for us to give language, to make the correction and then also give language.
Wow, you talked about frameworks and how existing frameworks, right, were outdated, needed to have the right people at the table to develop them. And one of the other publications of yours that I really enjoy is the one where you talked about the APs, and I know it's also going to feature in this series where you talk about really the perspectives and proximity and really building on existing frameworks in this work. So what did you find as you were getting ready with this work and publishing it?
Yeah, so what we found was just that in the literature, a lot of things that were holding providers back from having sexual health history conversations, period, were their lack of understanding, lack of comfort with asking these types of questions that they consider sensitive, right? But these aren't sensitive questions. If we look at sexual health as health and look at it from an assets based framework versus a risk based framework, people have sex since the beginning of time. Like, I don't know a time in
Period.
the of the world where people didn't have sex. So having an opportunity to share with clinicians how they can think about it as a holistic part of people's health was really interesting to me to figure out how we could reframe risk with that in mind. Like, how do I reframe risk or reshape risk with a bunch of people who won't even talk about it, period? So I think
Period.
that was really interesting to discover throughout this. But what we found was that people, if given some language, given some tools, they're really receptive to I hate to use the word parroting, but like just really reading off your question versus having to think of how they
To
would say it
think about
themselves.
how, yeah, I knew you really talk about, the whole thing with, practice makes progress, progress over perfection. And a lot of times you guys did the work to look to what was holding people back, right? When people don't feel comfortable or have the tools, and you're providing people with not just why it's important for you to be part of this work, but this is how you can do it. And that's why this kind of work is so important, because it's not abstract. And that's what happens when you have clinician researchers. You're not just sitting in and writing the research, you're
Right.
interfacing with patients. You understand on the level of the end user what are some of their barriers. So thank you for doing this work, which leads me to the last part of this part before we close out, which is, why should we care? Why should everyone pick up this paper, read it, and figure out how they can adopt this in their practice? Why should we care?
Yeah. You should care because black women are dying. And black women are having a lion's share of new HIV diagnoses among women. Black women make up approximately 13% of the US female population, but over 50% of new HIV diagnoses. And that's just HIV. We're not even talking about sexually transmitted infections and other um, issues of sexual health that we don't get enough into in terms of
Yeah.
pleasure and satisfaction, sexual satisfaction. So we should care because black women are um, disproportionately impacted by sexual health issues, but not spoken to in a way that would change that. And so if we can't care about a community that cares for everybody, what are we doing?
Couldn't have said it better. Thank you so much for sharing that. And I love that you're doing this and saying that, you know what? where women get their care, we should be prepared and ready to have these conversations with them. And they're coming in, they're saying they're primary care providers. Nurse practitioners are providing a lion's share of that work and care, and you're equipping people with the tools to have those conversations. So again, the full, go ahead, please.
And they're having these conversations, and they should be providers, clinicians, nurse practitioners, as you said, are taking up the lion's share of primary care visits. They should be initiating these conversations and not waiting for Black women to come in either with a problem or with a question themselves. I've talked with a lot of Black women out in the community, and they say, well, I'm having to bring up prep to my provider, or I asked about this. That shouldn't happen. We have to give providers, nurse practitioners, clinicians the tools to have at their disposal that they can readily ask and interrupt the silence that we've had around sexual health.
Wow, this is great, and that nailed it perfectly. So before we close out, in this short time we've had together, I have two questions for you. And one is, and I ask that of everyone I'm talking to, what keeps you going in this work as a clinician, researcher, educator, advocate, all of that? And two, what one piece of advice would you have for a person that's newer and trying to do research in this field of HIV?
So, what keeps me going is really the work. I'm super passionate. I have a personal story about what got me into this work, right? And so, being an advocate and a voice for someone who didn't have one at the time of their diagnosis, a Black woman at the time of her diagnosis, being an advocate for providers that I think she should have had and needed, I think keeps me going every day in this work. And then the community as a whole. I love the community, and I feel like if not me, then who? Okay. And for any advice that I would give for people interested in getting into HIV prevention work specifically would be find partners. You can't do this work alone. It's lonely work, particularly in our current climate. And so find your people, find your tribe. There are a lot of people out here doing the work, researchers from advocates to boots on the ground, the community-based folks. Get with those people. See what the streets are saying. See what people actually want and need, and be the voice for that, and come up with something that meets that need, right? Don't get in silos of, oh, I know what needs to happen because I'm Black. I could do that, but I could what has been most helpful has been to get with what's going on in the street and answer the call.
Wow, truly, truly listening to understand and acting on it. So thank you so much, Dr. Johnson, for having this conversation. Again, our goal is to demystify research, talk through it, and hear directly from the researchers. So in the show notes, you'll find out how to contact Dr. Ragan Johnson, how to read up about all of her other fantastic work that she's doing. So thank you for joining us. And really, what, and why. We heard about what the unmet need was, what Dr. Johnson and her colleagues did, what they found, and why we should care. So again, reasons over risks, nurse practitioners, and HIV prevention for Black women. Thank you, Dr. Johnson, for joining me today on this conversation.
Thank you so much.